Okay. Hello, good afternoon, good morning, depending on the part of the world that you're in. Thank you, everyone, for joining us today. My name is Zohreen Badruddin. I work for the Paris Peace Forum. I'm going to give a really short introduction to this webinar before I hand it off to our amazing team and panelists who are gathered here today. Bonjour, je m'appelle Zohreen Badruddin, je travaille pour le Forum de Paris sur la paix. On aura ce webinaire en anglais, donc je vais parler un peu en anglais et aussi traduire un tout petit peu pour nos francophones. Vous pouvez afficher vos sous-titres, c'est tout en bas du Zoom. Si vous tapez sur plus et après il y a une option pour afficher les sous-titres. So thank you everyone for joining us on this webinar on child and maternal health, specifically looking at democratizing child and maternal health in the African context. This is a webinar that is put on jointly between the Innovation Foundation for Democracy and the Paris Peace Forum, and is in the broader framework or in the broader experience of the Africa Forward Summit that is going to be taking place in May, where we and several other partners are going to be putting together a social innovation pavilion. And I'm going to let one of my colleagues talk a little bit more about that. But today's conversation is going to focus specifically on interventions in child and maternal health by my incredible colleagues here who all have on the ground implementation and or research experience to talk about one specific intervention from their organization's contexts, and to share learnings, why that works, and how that's an important example for scaling and something that can be used to promote child and maternal health throughout the continent. We will have hopefully a moment for audience Q&A as a part of this session as well. Please feel free to use the chat while our participants are speaking and sharing their presentations, and we'll be monitoring that and asking those. And there'll be a moment after all the presentations are done to raise your hand and to share your question aloud, whether that's to one specific participant or whether that's to all of our panelists in general. We'd also love to hear, I know we've got certain members in the audience joining us today from different organizations who you yourself have experience in child and maternal health in Africa, and we'd love to hear your experiences as well in that latter section when we're able to open up the mic. So without further ado, I am going to pass the mic over to Professor Achille Mbembe to share a little bit more about the social innovation, or the Innovation Foundation for Democracy, and the work that is going to be taking place in Nairobi in a month's time. Professor?
Thank you very much, Zohreen. I won't speak for too long. I am delighted to see such an eminent panel put together at such a short notice to illuminate us on an issue that is absolutely critical if Africa is to go forward, the issue of maternal and child health, the issue of how to strengthen it, how to democratize it, at a time when, as we all know, there are all kinds of pressures those who intervene in this crucial field are facing. And as the director of the Innovation Foundation for Democracy, which is spearheading the pavilion in partnership with the Paris Peace Forum and ICG, I would like to thank you for giving some time for critical reflection on this. As Zohreen said, the purpose is really to prepare a white paper which will be submitted officially to the heads of states and governments during the Africa Forward Summit. The white paper includes 6 chapters. Maternal and child health is one of those key chapters. The others have to do with equally important challenges the continent is facing, whether these have to do with the management of its natural capital and mineral resources, or whether they have to do with these issues with reforming our institutions or mobilizing new digital technologies at the service of the rule of law, or whether they have to do with the futures of international solidarity, etc. So as you see, you're not alone. You are part of a powerful set of voices we hope will resonate at the summit and argue once again for bringing back our societies at the heart of any transformation effort we are undertaking. And we'll do it with confidence because we are on the ground. We know what is going on. We know what resources our societies and communities do harbor. And we are looking forward to ways of mobilizing them and deploying them for the betterment of a world we see very well is in distress. So I will stop it there and we'll listen to Vania, to Laurène, Aquinius, and Zohreen herself. And I wish you good luck for the webinar.
Fantastic. Thank you so much. So to start this off, I think we are going to go in I suppose we'll be polite. We'll do ladies first. So Vania, I'm going to put you on the spot and have you kick us off. And for each of the three of you, feel free to introduce yourself and your organization to give a little bit of context as well. But I can, very, very quickly say Vania Kibui, who is here representing AMREF Health Africa. Please go ahead.
Thank you. Good afternoon, everybody. Thank you, Zohreen. And thank you, Achille, for setting the stage. In reference to the context within which we are really programming for maternal health and what our public health indicators could really look like, and what really look like now, and what interventions we believe would work. My name is Vania Kibui, as Zohreen has introduced. I am Kenyan by nationality, but I like to say I'm a citizen of the world. They say that you're a local wherever you find yourself. I work with AMREF Health Africa based in Nairobi in our HQ, and I sit in our Group Programs Director office as a senior advisor, policy advocacy and strategic engagement. And most of my time in this career has really been on maternal health. So I was very excited about this opportunity. So I'll very quickly go on the context of what I will share. I can begin by just seeing whether my screen will work. Sometimes it confuses you when it's a lot of things going on there. Let's see. We're good? Yeah. Okay, it tells me participants cannot see your screen. So now let me make it such that it's It's loading a bit slowly on my side, but I'll start. So when we were considering the kind of intervention that we were going to share, for those of you who know AMREF, you know that we have a long history in programming with communities across the African continent and, in partnering in the world and bettering health systems from a community perspective with over 70, almost a bit as older than we are, but almost 70 years, implementing with and partnering with communities for better health outcomes and health access for all. It was like a tough ask to be like, okay, just pick one and make a very short presentation of it. But we thought that it's a really great opportunity to show where innovation, scalability, and a community focus looks like. And the fact that we still do have very many underserved contexts and communities within our countries. And so this is
Vanya, I'm
can you,
I'm so sorry to interrupt.
yeah.
Just so that you know, we're seeing the speaker side of the presentation. So
Um,
I think it's probably the exact same thing you're seeing on your screen where we can see sort of the next slide and the notes. You may want to just change the format so that it's the
okay.
large screen for everyone.
Yeah, okay. Let me check that again. Sorry. Uh, and how do you do that? Let's see. Display settings. Okay. I see what you mean. Thank you for bringing that. So maybe I think it's the settings I pick when I'm sharing the screen. Or if you have it on your side, you could also if you, oh my God.
I'm pulling it up on my side. How about you continue with your introduction and then I can share
Okay,
it from
fine.
my side.
Okay, good. Thank you. That will be useful because I think it'll help us move along. Um Yeah, I think you can pull it up for me and I can proceed. Yes, so the presentation you'll see is based on that a bespoke intervention that we have been doing through our Ramka team in Malawi. And this is in a rural district in Malawi by the name of Balaka district. And we picked the intervention has been focused on two areas. That's the Kitawanda Health Center and the Zibe Health Center. And we have been programming in Malawi for quite a bit. And the reason that we looked at that this was the area of focus was, of course, our overall goal is to improve maternal health, and not only in that country, but across our contexts, maternal, newborn, and child health, and adolescent health, of course, right? And improving outcomes in underserved and rural communities, and strengthening both community and demand facility and readiness. So when we looked at, okay, so you can go to the next slide. Thank you. And so when we looked at the context here, you will see that Balaka, compared to the rest of the country, has had a higher teen pregnancy as compared to the national, I would say, national average. And one of the other, so we kind of assessed what the bottlenecks to maternal, to our RM and care services looks like. And one of them was this late antenatal care initiation, which we know is connected to provider-based, like skill-based deliveries. And so that was one of the contributors of the numbers you see here. And then we also saw that in terms of what is recommended for antenatal care, they had fewer antenatal care, incomplete antenatal care coverage, where you'd have four, they'd have maybe two, which is 50% of the visits, which was much lower, a bit lower than the national level. And it also occurred when it came to women who are older, where you'd find community perspectives differed and it interfered with a woman who'd had many children before, and her thinking that she doesn't need to go for as many antenatal care visits. And then, of course, we had this infrastructure gaps that restricted access. So as we said, it was more, I would say, very bespoke in terms of not as large scale, but because of the size of the population that the facilities served, we saw a real opportunity there. Next slide. So the intervention has been based on multi-level systems. There's community level, facility level, and systems level intervention. And the reason we picked this is because when we're having this bigger conversation about what it will really take to invest or change the conversation about how we invest in maternal health, we need to kind of look at the communities that are attendant to or need the services from a multi-sectoral lens. And so at community level, the intervention we had were, for instance, here, the secret mothers and village health communities. So secret mothers are volunteers who kind of give a confidentiality aspect to service delivery at community level. So women feel more comfortable. Like, for instance, as you see where there's delayed ANC as initiation, and maybe because you know what happens with women sometimes with communities is that you find that the decision as to whether a woman is going to to go to a facility is usually not solely hers, and then there's also familial and community interactions. And so when you have somebody who comes from the community who looks like you, who understands your situation, you're able to go and see her and this was implemented with an end to improving ANC. And so also we've had village health committees where we are also able to share the information from the facility in terms of what's happening there and the services that the pregnant women can actually access into the community where actually the women actually exist and live their lives. What we also did was early pregnancy identification and follow-up. And community dialogues on ANC and skilled birth attendants. And this is where we have our community health promoters, and you're going to see like district health, district level volunteers, and also district level health officers in terms of access to commodities, and then youth targeted SRHR outreach. So at the facility level, as you can see, we had this an integrated approach to services. There's maternal and perinatal day surveillance, health workforce supervision, mentoring and training, and kind of really linking that to community health and essentials commodity availability, especially for children, for instance, who needed essential medicines, because we found that there were often stockouts that spoke to procurement issues, and so we were able to connect what the needs and the demands have been at community level, work with the district health officers who then can address the pipeline for procurement. And at systems level, of course, and we also chose this because of the fact that we were laying this on the foundation of already existing pipelines with district health management engagement, routine data review and quality, and policy alignment within national frameworks. And really that aspect of sustainable financing. Next slide. So what we have so far has been very, I would say, encouraging, because when you get data that confirms that the approaches that you're implementing, it can be very encouraging. And so we found that we were able to actually reach our goals in terms of the outreach, that the community outreach was working with the clinics, and so ANC increased, and not only initiation of ANC visits, but completion. We found that more women were reached in this time, that even improved the general average of the district for integrated services. And then this aspect of community-based like district assistance was really good because it kind of created a community level infrastructure for access to services, and continuing family planning continuity was restored, and like really that continuum of care. And in the time that we've really been implementing this program, we've seen zero maternal death during this time. And I think it's been very encouraging, and it's a success because we haven't had for a long time in the continent really exciting. Like, it's exciting to have something that speaks speaks a different narrative to what numbers say. And as you can see here, the facilities that we've been supporting during the existence of this project has gone up to like 64%, like double the percentage of ANC care as compared to before the intervention. Next slide. So what are we learning? Because I know we were supposed to like just do very quick highlights, but we'd be happy to share a bit more. We've learned three core things, and the first one is that community engagement matters. It matters that women and people and women and people in communities and adolescents see themselves in the continuum of care, that they see themselves they see services as being responsive. And so this intervention of secret mothers that I just shared, voluntary health health promoters, that they help us to have early pregnancy identification, which we had seen was a big problem, and also pushed for early ANC visits. The monthly supervisions build accountability, really trust and continuity. That's the word I left out. Trusting healthcare systems is a really big win of community-based interventions. And community dialogues shifted norms around ANC and timing, because now communities began to see the responsibility they care in the well-being of pregnant mothers in their society. And alignment and partnership alignment. So we collaborated very closely with district health management teams. And this is very core when it comes to speaking about sustainability, using already existing systems for data, for procurement and access to medicine, even for training, is really important because it creates an infrastructure that the government can invest in financially and can be built on by other partners. And so they become the owners of the process. And then integration, I've spoken to this. Data integrity was a big problem, but then this alignment is one of the issues that we sought to address with good results. And the use of government facilities really strengthened ownership. And then data-driven adaptation, as I said, first of all, we needed to make sure the data integrity, like the data is telling us the right thing. But then the frequency with which we were collecting data has enabled us to adapt as we go along. So even as we speak, which will come on the last slide, there are interventions we're thinking of adapting, and we are okay saying, oh, actually, this particular intervention didn't work, and we're thinking of adapting it in a way that actually works for the communities, and actually going back to funders and donors and telling them these interventions didn't work and these are the proposals we're making. And so real-time stock and monitoring has prevented commodity gaps, which we know in maternal health has been a real bottleneck in terms of access to medicines. And performance tracking has enabled us have a rapid course correction, as I've shared. We do have some challenges that are remaining that call for investment, and like, for instance, maternity waiting shelters. And those of us who have implemented in rural areas know the burden of a woman who lives very far from a facility, and the danger and the benefit that there would be in a waiting shelter as she waits to deliver her baby. shelter and equipment. So cultural beliefs in terms of delaying ANC, I've spoken to that, and limited youth friendly service platforms. As we know, youth are not a amorphous block where they also need that one intervention will apply for all. So part of what we're looking at is building I would say responsive engagements that actually create awareness for adolescents and young people on SRHR and contraceptive information where they are in youth clubs and schools. Next slide, because I think this is yeah, so for scalability, I have just one more and then I'll leave you to the rest of my colleagues. When it comes to scalability and transferability, AMREF is very passionate about building scalable and replicable models. We believe that if we're able to pilot and implement and get to proof the proof of the approach, it's something that any partner and especially government can take up and run with. So we have this model uses existing primary healthcare and community systems with an end to expanding them and really investing them and making them more efficient. It's low cost has replicable components, which we have all used before, And so sometimes we say innovation isn't always about the newest thing. It's about also looking at what already exists and making it even better. And so outreach, volunteers, and supervision. And so this modular design, and then the next one is that the modular design has helped us have a phased implementation, and we haven't created parallel structures to what already exists. So what you see there is like what we have in terms of our modular approach. And then one of the things we've learned is that it's a cost-effective approach that as it leverages existing infrastructure and cadres low-cost enhancements, which are within $200,000, and moderate investments would support an expansion for commodity access and really an empowerment program. So that goes to my next slide, which I think is okay. This is also what we've learned in terms of the learnings. Second last, classic African style. I promise you second last slide. So we have embedded this approach within already existing systems, as I said, through government facilities. We work directly with district health management, who are able now to use the next point, which is the national data systems, to speak to what the needs are and what the financing would be to help evidence-based decision-making on financing more clear. And it strengthens what especially community and facility level systems and cadres, I would actually say, health systems, assistance, and community-based district assistance. And it does institutionalize supportive and supervision meetings. It has improved commodity monitoring, as I've shared, and really built community ownership and even this responsibility of reducing maternal mortality in as a community in this area, and has shifted from one-off activities to kind of this repeated management practices. So as I've said, it doesn't create these parallel systems and strengthen what already exists. Next slide. So this is the last one. You see, I made my promise. I kept my promise rather. So looking forward and the scaling opportunities that we see is that there could be, we've kind of done this scenario planning and categorized them because we know resource constraint is a reality. That's one. And two, when you're working with like our local and national governments, it's good for them to see what is feasible now and in immediate term and long term. And so that's how we are looking at the future. And so what you see here in terms of the catalytic investments or catalytic opportunities for scaling really builds on already existing approaches like texting kits for community health workers, integrated outreach and expansions that actually really skills its focus on young people and adolescents in terms of their health-seeking behaviors, and community health systems assistance, performance management, and hotspot focused in pregnancy work. Then you can see in terms of the next offering is really this adolescent empowerment package, which we have. It's an approach that we have seen work in other contexts like Ethiopia and in some cases in Kenya. So we believe that it's something that would also work here and something we are looking to build towards. Enhanced commodity access is something that we would continue doing and is quite needed. Community mobilization to drive up demand and continuous training. In terms of brick and mortar, I would say maternity waiting shelters, as I talked about. Now, for youth-friendly service corners, we had gone in thinking that this is what we need. So we are rethinking this and adapting it more towards outreach. So this will actually look different, although the data initially was telling us, or the assumptions that we made initially were telling us something different. And then this link to livelihoods, as we invest in our kind of social determinants of health, technical thinking at the moment, and strengthen referral systems. So as I've said, each of our scenarios has built upon proven approaches, not only in Balaka, but across our other programs. That's my last slide. The next one says thank you. Thank you for taking time to listen to us, and also thank you to the Paris Space Forum for this opportunity. And we're very excited about the right paper that this will build into. Thanks again.
Fantastic. Thank you so much, Vania. I'm going to pause the screen sharing just there. But if you'd like to share sort of your contact details or anything, please feel free to do so in the chat in case people would like to reach out to you, because I didn't leave that on the screen for very long. And thank you for sharing that. There's so many different pieces that I can pick up on, but I'm going to hold off until everyone's done their presentations, and then I'm going to circle back. And so if I can ask Laurène Petitfour as our second speaker, who is representing the Institut de Recherche pour le Développement, or IRD as we say in French. Laurène, would you like to share your screen?
Good afternoon, everyone. Can you see it?
It's good on my end.
Great. Perfect. Good afternoon, everyone. I'm Laurène Petitfour. I worked at the CESTIM, a research unit of the IRD, and I will be talking today on behalf of the TRIMOM group about the TRIMOM project towards elimination of HIV, syphilis, and hepatitis B virus mother-to-child transmission in the Gambia and in Burkina Faso. So TRIMOM stands for the Triple Elimination Model of Mother-to-Child Transmission Program. First question, why considering these three infections, HIV, syphilis, and hepatitis B, all together in a triple elimination agenda, as it is said now by the WHO? A few reasons. West Africa is one of the regions in the world most affected by HIV, syphilis, and hepatitis B. We have a high prevalence of these three infections among pregnant women, and an excess morbidity and mortality associated with these three infections in this region. So that's the first reason. The second reason is the importance of mother-to-child transmission in the new infections that are happening every year still today. The third reason would be that co-infection between the three infections increases the risk of transmission for the other two infections, which justify considering them all together as well. And the last that we can speak of would be that mother-to-child transmission can be prevented through simple and effective interventions. From the screening side, we now have simple and reliable rapid diagnosis tests that exist. And from the treatment, prophylactic treatment, we do have effective treatment that also exists. So all these reasons together made the WHO call for a triple elimination agenda with an horizon at 2030 through an integrated and coordinated approach, which raises a lot of implementation challenges. Last implementation challenges. In most countries of this sub-region, we have two separate verticals program. Namely, one would be for HIV and sexually transmitted infections, and another would be hepatitis program. They work separately and they have very different level of resources, which creates inequities in access and low coverage for screening and MTCT. MTCT is still now safe for mother-to-child transmission. Prevention measures for syphilis and HPV in pregnant women. So in most countries, HIV services would be fully free, while syphilis services would be partially free. HPV services will be all user pay in most countries, except for vaccine at birth, for instance, in the Gambia, where we are working. So this explains some low coverage for HPV and syphilis testing. Also, examination and treatment for syphilis and hepatitis B might not be available in primary healthcare services, while it's where pregnant women do follow their antenatal care. So all of this creates a fragmented and costly care provision. And we can put that additional hurdle and challenge women's social and economic vulnerability, some potential exposure to violence, which can create some refusal of testing or withdrawal from care, which will increase the risk of mother-to-child transmission. So all of that gives challenges that the TRIMON program try to address, with the primary objective to develop, implement, and evaluate a simplified, integrated, and coordinated strategy for the triple elimination of MTCT, of HIV, syphilis, and HPV in 8 maternal and child services in Burkina Faso and the Gambia. And here I can already give you 3 key features of the program. The first one that I was already a bit talking about was the use of the rapid test diagnosis. That it's something that we rely on for the screening, the triple screening. The second one is the integration within the health system, so activities are embedded in existing antenatal services. And the third one would be the coordination between different programs for HIV or hepatitis B, for instance. And that is a key of the program as well, key feature. So what would this intervention, what does this intervention encompass? We have 2 pillars in this intervention. The first one is the straightening of the screening for the 3 infection. So it's very concretely a free triple screening for HIV, syphilis, and HPV using rapid test diagnosis provided to each woman coming to seek antenatal care. And this, of course, requires the training of healthcare workers that are in charge, of maternal health. The second pillar of the intervention is the improvement of access to measures of prevention of mother-to-child transmission. And this means assessing and treating each woman that who is positive for any of the 3 infections. So providing the treatment, but also counseling, and raising awareness on prevention of mother-to-child transmission and empowering infected women, in our case, women in general, but in our case, it's mostly infected women, to make them more conscious and proactive in the management of their disease and infection so that they can make their choices as they want to and have some agenda in this process. Our target population was 17,000 screened pregnant women, 5,000 in Burkina Faso and 12,000 in the Gambia. And these 17 screened pregnant women would be located in 4 study sites in Burkina Faso and in 4 other study sites in the Gambia. And how is it happening? So first, before the beginning of any activity, we did a cross-sectional survey. It was a mixed method survey among postpartum women and among healthcare workers to have a broad overview of what was happening in terms of screening and prevention of mother-to-child transmission regarding the 3 infections. Then the activities began, and how is it implemented in practice? When a woman comes for her antenatal consult, she would be offered a triple screening with rapid diagnosis test. This should be free and systematic, Of course, she can refuse it, but at least it's systematically proposed with no user fee. And if she is positive to any of the three infections, then she will be offered care for infection, especially preventive care, for the risk of transmission to the baby to be decreased and limited to the minimal. And she will be also offered to participate into the triamum cohort, which is mainly consists in data collection throughout the pregnancy and a bit after. So if she, as I was saying, if she is positive to any of the three infections, she will receive a medical follow-up all along her antenatal care throughout the pregnancy and up to 6 months after the delivery for her and for her baby, until a final assessment of the health of both of them, until a final. And a specificity of the program is that in addition to this medical follow-up, we provide a psychosocial accompaniment by peer mediators within the health facilities. And the peer mediators, they would provide support to women, information. It can take the form of group talks, it can take the form of individual discussions, of phone calls. And the objective is really to improve health literacy, information, and to help women face any challenge that they could face regarding their healthcare or their personal situation. So that's the rollout of the intervention. A few insights that we got from our first initial assessment from our mixed method survey. We observed a very low screening coverage for the three infections, around 30%. And there are two sides to this coin. First side is from the healthcare worker side. We have a limited knowledge about hepatitis B and syphilis in healthcare workers. So this is, of course, a major barrier to the offer of systematic syphilis and hepatitis B screening. And from the women's side, we have a very low information about also syphilis and hepatitis B, especially low health literacy, some vulnerabilities of different dimensions, psychosocial, economic, individual, complicated family situations that are hurdles to triple screening. Some potential experiences of violence during pregnancy. We found a prevalence rate of violence about 10%, which can have consequence of mental health, access to antenatal care, and other consequences as well. A few preliminary results from our cohort of women that were tested positive to at least one of the three infections. We're very happy to have a very high acceptance rate of the triple screening, higher than 95%, which means that we could triple screen almost 13,000 women in the Gambia and a bit more than 4,000 in Burkina Faso. We found that almost 5% of women in the Gambia were tested positive for any of the three infections, with a high burden of HBV and also an HIV infection that was quite prevalent. In Burkina Faso, the prevalence of the three infections together was even higher because it's almost 10%, which is quite high. And it includes infections through HBV and lower infection, relatively lower infection of HIV and syphilis. And we could provide treatment coverage for the three infections to more than 80% of the women. A few implementation insights throughout our qualitative data and throughout the rolling out of the program. There is really a differentiated integration of PMTCT activities into the different services. HIV PMTCT is way more established within healthcare provider practices and organization structures, while PMTCT for HBV and syphilis remains more project dependent and various on the field. It's only partially integrated within HIV services. So this is an harmonization. There are needs of training, coordination, and reorganization of some services to provide a real triple elimination strategy. Adherence and retention into antenatal care and treatment may be challenging. Providing free care is essential and it's necessary, but it's not sufficient because there are many situations and it's in many situations and hurdles, multidimensional hurdles. So the crucial importance of improving women's health literacy through high quality information, psychosocial support, a follow-up that would take the form that they need, and not only a uniform way of follow-up is essential. And that's why in our case, the key role of peer mediators was really, it was really something that was crucial. And this is also linked to the increases of men involvement to not only screen the women, but also screen their partners to increase the adherence to the treatment, increase the support of the infected women in their health care, reduce violence and hurdles to treatment. This is also something that needs to be worked on, sorry. And a few next steps that I will go quite quickly on because this is still ongoing and we only have, as you saw, preliminary results. This is ongoing project. But in terms of scalability, the treatment program aims to provide decision maker with information on impact on the cascade of care, child health through the avoided infection and cost that we are collecting data on through the cohort and through our microcosting study, and also through a qualitative and process evaluation study on factors that are likely to facilitate or hinder implementation of PMTCT. And the last thing that I will stress is that the training program is really embedded in healthcare system, so that the training tools and the teams were within the existing maternal health services facility. So, and we are working in partnership with the national HIV and hepatitis B programs in the building of the program. They were involved from the beginning, national program health authorities. They are involved in workshops that are organized in the training of the healthcare workers, which is a pillar of the program. And they are also involved when we're diffusing the program and its results throughout the international community. And I will end on this because they are like mostly the one that are implementing the project that I was just reporting on finally today. So here are all our partners, and I will thank you for your attention and your time. Thank you all.
Thank you so much, Laurène. It's interesting to see you're saying, of course, it's still in preliminary stages, but even the data that you've presented is really incredible to see, and already seeing certain parallels with the learnings you have and some of what Vania was talking about as well in terms of what makes the project work. So definitely going to come back to that, but I am keeping an eye on the clock here. Before we move to our last presentation, I'm going to ask our listeners, feel free to use the Q&A button if you've got any questions or any comments for any of our speakers. And of course, after our final presentation, we will have a moment to speak and to discuss. So if you don't already have questions, pay extra special attention because this is your moment to prepare your question so that you're able to ask it after our last presentation. And so without further ado, we have Aquinius Mung'atia, who is representing the Aga Khan Health Services East Africa.
Good afternoon. Thank you very much, Zohreen, for the introduction. My name is Aquinius Mung'atia. I work with Aga Khan Hospital, Mombasa, representing Aga Khan Health Services, East Africa. I'm going to share with you some of the experiences we have with strengthening RMNCH systems in East Africa, based on our project, which was more of community-driven and a lot of integration. So we chose to share with you this specific project, which was localized both in Kenya and Tanzania. In Kenya, the project was called Access, and in Tanzania, the project was referred to as Impact. This is one project which was running for a period of five years. Let me remove the cursor. Sorry, a moment. Okay. Okay, thank you. Sorry for that. So I was saying that this is one project which was localized both in Tanzania and Kenya. In Kenya, we had the project being implemented in Kilifi in coastal region and Kisii in western region. And in Tanzania, we had the project being implemented in Mwanza region for a period of 5 years. The project basically has been, sorry. Okay. The project basically was one of the most successful projects, and a project which has been scaled up by many other projects we have been doing in both East African region, but for the fact that it helped to address most of the challenges and many of the challenges within the RMNCH service delivery and service availability. So the project was both in Kenya and Tanzania was addressing the challenge of high maternal and child mortality, basically being brought about by limited service availability, weak health infrastructure and equipment gaps in the facilities you're working with, a lot of gaps in water and sanitation and hygiene, and also infection control, infection prevention and control practices. We noted we had a lot of low community awareness, a lot of knowledge gap, limiting access and utilization of these services in our facilities. Also, there was limited and very weak rural access to RMSH services, and also referral systems. Either they were weak or they were causing a lot of delays in both Kenya and Tanzania. The assessment also could note a lot of gender norms which were limiting care-seeking behaviors, especially male involvement and resorting partly to some of the gender-based violence cases we're seeing. In the facilities, we had a lot of workforce skills gap and shortages. And of course, in Kenya, the frequent healthcare workers strike. We noted a lot of health management information systems weaknesses, especially at all levels, especially its use. And also, there are very frequent external disruptions in terms of extreme weather, food insecurity, pandemic over that period, and of course, every national political elections brings up issues. So these are some of the things that the project was attempting to address in both Kenya and Tanzania. The intervention model that the project was using was basically integrated community facility system approach, which AMREF has referred to as a multi-level system approach, which now I can confirm we're sharing in common. So the integrated community facility system approach is looking at the continuum of care, not just the interventions that we are taking as a gap fillers, but as interventions that will touch every part of the community, the facility, and the system to be able to alleviate the challenges that we're facing. For instance, in Kenya, we had facility upgrades, over 10 facilities. In Tanzania, we had over 80 facility upgrades, major equipments, and for instance, given a case of anesthesia machines giving, we had a lot of works with the strengthened referral systems, including with the CSPs in the community and transport support. We trained a lot of healthcare workers, mentored healthcare workers on key topical issues, BMOC, CMOC, gender-based violence, RAMCA, topical issues. We also went to the community to strengthen the community units and also the community health committees, enhanced the data in terms of the health management information system, both in the quality of data and also data use. and also in terms of digital health, looked at the e-learning and remote mentorship. A lot of community mobilization works happened, both on the space of MNCH and also SRHR initiatives. One of the key areas that we looked at also was the community-led total sanitation. We had a lot of villages with open defecation, and by the end of the project, we had a number of 5 communities that were certified as open defecation free in Kilifi County. Also, we noted a lot of challenges with sustainability, and for instance, the CHPs, the community health promoters in the areas that we're working with, were able to form income generating groups and to be able to support them with seed financing for them to be able to sustain the groups both as CHPs and also as community for community health committees. Again, the project was supporting a lot of governance strengthening and multi-channel community engagements in the various forums within the sites that we were working in. So in Kenya and Tanzania, just to give a snapshot of the evidence of impact, we were able to reach over that 6,000 women with family planning and also increased immunization coverage. Male support increased, CHP data quality increased. I've mentioned about the open defecation free certified villages through the community-led total sanitation. There was a lot of increased youth and adolescent sexual reproductive health awareness, and then income generating activities improving community health volunteers retention and performance. In Tanzania, we had around 200,000 and 7 community members reached with almost 174 households visits and almost 3,000 community health workers referrals. A lot of awareness with almost 144 radio episodes broadcast, with recorded improvement in emergency obstetrics and newborn care capacities and facility improvements, of course, for climate resilience and support. For Kenya, specifically on service delivery, the project increased deliveries in supported health facilities, which increased from 76.9 to 86.7, with specific areas of increased access, scaled deliveries, of course, facilities providing BMOC, and because the reason for looking at this indicator was because of the increased maternal and perinatal deaths. Both BMOC and CMOC was one of the key components of our capacity building and mentorship in the community. PNC mothers, newborns, ANC, and also looking at children 0 to 5 years with diarrhea, and also with under rehydration programs. So basically, in service delivery, we unskilled but attendance improved by almost 5%. ANC, the fourth, increasing again by almost 7-8%. All the facilities we are dealing with, gender responsive facilities, increased. We didn't have most of the facilities in terms of gender responsiveness were not, we're not supporting gender responsiveness, BMOC readiness, infection control, and the maternal satisfaction, as you can see, overall increased by almost 5-6% by the end of the project. In terms of efficiency, we had reduced delays from the referral systems. The health departments and health facilities started using the health data in planning, and a lot of coordination across the health systems in all the levels. So from the project, we earned a lot of implementation insights. One of it is the AKDN there was a strong collaboration between AKDN, county, Ministry of Health, and community partnerships. The project ideally was developed through co-creation, where we look at the needs in the community in partnership with the community and the health managers, and that strong correlation actually helps sustain, because as I've said before, the projects completed, but there are many other projects that have picked up from this project sustaining, and even if you go to the ground at the moment, you'll be able to see the scalability of the works that we did under this project. Again, another learning that we can get is adaptive management during strikes and during the pandemic, driven decision making in the counties based on the data accurate quality data capturing from the facilities and the community, and the use of that data at the county level systems, at the regional level systems in Tanzania. We have a lot of learnings from the community-owned actions, such as the community health committees and champions, policy arrangements within the community health strategy and national guidelines and policies. I mentioned a lot of mentorship that strengthened BMOC and CMOC quality, reducing and of course the aspect of surveillance. The MPDS surveillance came in with this mentorship. There was a lot of integration in terms of the facility community strategy to increase demand, and partnerships with the government to increase accountability. Some community systems, such as community-based saving groups and income-generating activities by the community health promoters, supported, helped to build financial resilience for this. That time there were volunteers. Then that boosted referrals in the community. So for scalability, we are saying that the intervention leverages cost-effective, community-driven, and digital approaches that could be replicated and adapted across several settings. For instance, the community health committee models is replicable across East Africa. E-learning and remote mentorship is scalable to all countries and regions. Facility upgrade model is replicable. We're using low cost, high impact, which are up to date. Most of these facilities are in use. Community-led sanitation and community, social behavior change communication is adaptable to local context. And I've mentioned about the strong community health workers driven referral model with the skills lab institutionalized for RAMCA trainings in the facilities that we build. A lot of government ownership through facility and equipment handover and integration. You see in some photos for in the coming slides on the handover sessions that we have done with the government, meetings, demand generation sessions that we have held with the government. And not to forget, we're looking at climate resilience facilities, greening of the facilities to provide shade, to alleviate advanced climatic conditions. On the county ownership and sustainability, for Aga Khan Health Services East Africa, we were doing memorandum of understandings with the facilities and the county on digital on the works that we are doing in the facilities for facility maintenance and digital platform maintenance that we established. Meaning, by the time we did the project for 5 years, the 4th year we let the government, the facilities input the costs in their normal recurrent budgeting processes, so then we can have sustainability. County budgets were covering the e-learning connectivities across all sites. Community governance structures remained active, and actually there a lot has happened by now, which has helped to keep these governance structures very active. Community health volunteers, most the groups that were registered as income generating activities have been sustainable, sustainable, and they're supporting a lot of referral mechanisms. And then also the project helped to institutionalize quality initiative cycles at the facility level. So these are some of the photos of the works that has happened in the community in terms of demand creation. In fact, in terms of community led total sanitation programs, in terms of awareness creation in the communities for the works. This is Kilifi County. This is awareness creation in Mwanza in Tanzania. As you can see, the inclusion of men involvement in these initiatives also were yielding fruits in the communities. These are some of the structures and equipment that we supported the health facilities with, basically to enhance some of the services, because if you do capacity building, for instance, on CMOC, and you don't have proper equipped operating theaters, then you may not be adding value, but we are looking at that continuum of care, that we train the health workers on deferral, we train the health workers on BMOC, CMOC, build the facilities, and then post the facility now, the monitoring, the surveillance, the MPDS surveillance comes in. This is one of the facilities in Kenya where a complete theater was built and equipped, working up to date. And this is the government involvement, which I was mentioning, our Aga Khan University president handing over the medical equipment in Tanzania. And this is the equipment in Kenya, in one of the western counties. And in conclusion, I'll say the project provided scalable, community-driven reproductive, maternal, and neonatal child health systems model for broader replication across East African region. This model basically is highlighting the value of combining community engagement, health systems strengthening, and data-driven innovations to improve maternal and neonatal child health outcomes. And both approaches, as you can see, are scalable. All of them are adaptable and support protection of vulnerable populations, strengthening national health systems. So, as I conclude, and I mentioned from the beginning, the two it's one project localized in 2 regions, which has been scaled up by many other Aga Khan health services interventions in the community, both in these regions, in Mwanza, in Kilifi, and Kisii Western and Coastal region, and other added sites, not only in MNCH, but also in NCDs, in SRHR services and all that. So thank you very much for the opportunity. Thank you.
Thank you so much. You've preempted some of the conclusions I was going to say from across all of the 3 presentations, which is wonderful. I think that shows just how relevant they are. I think it's really impressive. We've had 3 presentations from completely different geographies. The first one was speaking about Malawi, the second one about Burkina Faso and the Gambia, and of course our third one on Kenya and Tanzania. But to see that there are similar learnings coming out of a lot of these, and if I just briefly summarize, because I know we've got a couple of questions in the chat that I would like to get to. I think everybody's addressed the importance of contextualizing the type of work that is being done, whether that is to youth audiences, whether that's to intake elements of the culture and how that might be a barrier or a determinant in accessing healthcare, in making sure that there's peer support and community health workers who understand that context. There was also lots of mention of the importance of maintaining a continuum of care. Multiple visits, things being done at the prenatal stage, and of course things that continue after the baby is born in certain interventions. All 3 of our presentations talked about reinforcing government systems as opposed to creating parallel systems or building new systems, and related to that, the importance of data collection and feedback and adaptation in live time to different challenges, to different issues. Several of our speakers also mentioned having certain assumptions at the beginning and then the data not necessarily showing that out and needing to pivot, or in future iterations of the program maybe needing to do things a little bit different. And all of this, I think, is hugely important to making sure that these populations who deserve and have the right to quality healthcare are able to achieve those. So I'm going to ask all of our panelists to turn their videos on, because we've got a couple of questions that I'll ask to all 3 of you. And the first one is obviously through this white paper, as Professor Mbembe had mentioned. We are hoping to present this to the heads of state at the Africa Forward Summit in about a month's time, just under exactly. So for each of the 3 of you, if you had 1 or 2 key messages, key recommendations for President Ruto, for President Macron, what would you say your learning is? What is the 1 thing or the 2 things that the government absolutely needs to do or invest in to make sure that we have quality maternal and child care in all of Africa, in the countries that that you have run your interventions? That's for all three of you, so anyone can start.
Okay, I think I can start. For me, I think one key thing that I would put forth is the challenge with continuity of care, because sometimes of the lack of commodities in the areas that we are working with, and for instance in Kenya, the issue of healthcare workers. Most of the time you find the healthcare workers up on strikes. Not able to give the services required because of challenges with availability of commodities, and that breaks the cycle of care, and prolongs the intervention period, which will have repercussions on the outcome of care. I'll pick that one. I'll leave my colleagues to talk about the rest.
Okay. Vania, Laurène, a different recommendation for our heads of state. What would you say?
I was going to, if I can think of one, I think, because I've seen another question on the chat that made me also reflect on this. And because the question was, is the issue funding or coordination? And I wanted to say yes, and because what works is what is funded, right? So on one part, there is it's important for us to build on each other's wins, especially when we are like focusing in the same community areas, and collaborate together and really see the healthcare system as our entry point and really coordinate based on that. So that definitely always is needed. But also on financing, there's also this need for the sector-wide approach for us to understand what primary healthcare systems look like, what they need, and the financing they need like as a one-stop shop. So I think if I was to connect that to like one message in terms of the financing and like coordination from I would say a heads of state perspective, I would talk about financing, making sure that we are financed the access to medicines very effectively, because what we found is that there's intermittent access to commodities, and that affects people's trust in the system, and what they think is reliable and what they think they will find. So I'll connect that with the need to invest in community-based interventions, the things that we're doing in terms of making sure that communities are aware what is that they have confidence that when they go to facilities they will find care. And so it's connected to actually what Aquinius said. If you invest in the facility and we continue bringing the facilities and we continue bringing this demand up, it means that you're restoring the trust of communities in that they will find what they need. They will find the services that are dignified, the commodities that are needed when they go to facilities. I've said many things in one, so to different audiences, but I hope that's clear.
No, that works. And as you're saying, you're building off of each other, the two responses effectively. Laurène, echo the same response, have a different recommendation for our governments? What would you say?
Maybe I can go just like a step, I don't know, further, echo third time, and say that something that is crucial, that intervention would be simplified and coordinated so that there are not multiple entry doors regarding different pathology, different population, and everything. It's hard to build trust of people, and that they would go from thinking of seeking care to seek care. And so once this has been won, if I may say, it's important not to lose it, and having multiple entry door services that provide segmented care is certainly a hurdle to effectiveness of care. So having something that would be coordinated and simplified would be an additional layer to what my co-presenter have already been saying, I would say.
Well, I'll take it, even though it does sound like if I was to do perhaps an oversimplification of the three responses, it sounds like we need to redo significant amounts of primary care structures that currently exist. Because to your point, Laurène, about the fragmentation, it seems like there's quite a bit of that, looking at different countries at the moment. I'm going to take the next question, which is looking at the biggest barrier today to equitable access to maternal and childcare. We've talked about some of the different challenges that exist. We've talked about gender. We've talked about climate. We've talked about rural versus urban. But I'll leave it to the three of you. What is the biggest barrier in access to equitable care?
Maybe I can start. And its biggest is it's a tight spot, right? Because
One of many, perhaps.
yeah, I think that sorry, and as I started speaking, I kind of lost my point as I wait for it to. Gosh, I've lost it, my point. Please go ahead. I was writing and then I forgot. It's coming back.
Yeah.
Would somebody else like to jump in on the biggest barrier?
Okay, maybe from my point where I stand, especially in Kenya and working in coastal region, I may think of a structural barrier being more geographical and physical access, where the position in some of the areas are too vast, and you have that mother who needs to access a facility, the sick child who needs to access the facility, and they have literally like to walk miles to the facilities. Is one of the things. And also, when I talk about the structural barrier, I look at the rural versus urban inequality in terms of affordability of some of these, ability to get those knowledge and all that. So for me, I would look at the structural barrier in terms of geographical and physical access to care in terms of the facility, location of the facility, the inequality between the rural and urban, and also the issue of the referral, basically, which has caused more deaths than anything else. Is that and I'll give an example that you are in a rural facility where you require ambulance, and that ambulance will take 2 hours to get to the site that you need it. So that's an area of intervention which can really bring that access inequality. Thank you.
Thank you. That's a really good point. And I think unless people have spent time in some of the countries that we're discussing, it's hard to realize just how far some of these distances are. And you don't necessarily have the roads, the cold supply chain to get materials to the right people in an efficient, a time efficient manner necessarily, because obviously, as we know with healthcare, it's often time is of life and death consequences often enough. Vania, has your point come back to you?
It has. Thank you so much for giving me time.
I saw like an aha moment when he was
Yes,
speaking.
it came back from the ocean or wherever it had gone. I wanted to talk about the same way we talk about continuum of care. We have this kind of interruption of political will in terms of where funding goes. So if you look at all the interventions we shared, there's this insistence on community-based interventions, community-based care. And so there is some mileage that we have gotten so far in terms of integrating gender transformative approaches, even in the way that the health system sees women and adolescents and girls. And so building on these interventions will require significant investment, or let me say consistent investment and almost literally uninterrupted, which we can't, I don't know if we'll ever get. But it's because with each administration, sometimes even at local level, some priorities change, some things fall off, and it always means you're leaving somebody behind. And so I think I from where I sit, I think that that's the biggest barrier, in that communities are not seen as a whole based on the priorities that end up actually being what is being prioritized or what gets funding. So interrupted political will and financing.
Laurène, you had come off mute earlier.
Yeah, I was going to talk about the sustainability of efforts of and the intervention, and it's the funding, but it's also, for instance, the training of healthcare workers, because it's a sector with like a high turnover. It's the maintenance of everything, so it's the sustainability that has to be thought with all the dimension that it encompasses, and it's a key to the success of intervention and on healthcare system at the end. And it's actually certainly a big hurdle that it's not durable in the time on all dimensions.
And it seems like we keep circling back to that other question in the chat that Vania, you had also spoken to a little bit, is whether it's a funding problem or a coordination problem, where it almost seems like a chicken and an egg situation, where if you don't have the funding, the coordination isn't going to be great. And so the implementation isn't necessarily ideal. And you keep running through that series of problems.
Yeah, I think it's also the fact that coordination isn't funded. In that,
speak about that a little bit. What do you mean?
In that, okay, what we found when we were looking at, even a couple of years ago, we started conversations as AMREC with other civil society organizations that do advocacy work in health. And so when you look at service delivery approaches, so if it's this kind of vertical programming, right? And then you have service delivery approaches, or, okay, let's say you're looking at malaria, the other person is looking at TB, some of us are looking at maternal health and access to essential medicines for children. And it means that these vertical programs don't necessarily speak to each other. So that's also kind of a structural programming problem that then creates these silos that then make it difficult to kind of coordinate outside of your disease area. And so we need to know how, or rather, we need to have conversations of how this maternal health issue is connected to other health issues, right? Even if it's NCDs and all of that, right? So that then when I'm talking about mental health, with the person, or rather, when I'm talking about maternal health and somebody else is advocating for mental health, which let's say gets 1% of the public health funding, we're not seen as different folks, right? So it also means that even when it comes to the development sector, what you're funded for is what you do. So you are unable to hive off funds from what you get to coordinate with other partners so that then you make your advocacy message stronger. That's what I mean by funding coordination. Simply what you're doing as the Paris Peace Forum in this discussion. I think that there's a need for us to continue sharing learnings so that there's better coordination, so that you know who's actually doing what, where. That's what I mean. Thanks.
I think the speaking beyond silos is definitely something a lot of people would echo, of people in the know what's happening, but they're not necessarily the ones who are maybe making the financial decisions or advocating at the government level. And so there needs to be a lot more information sharing across the board on this. And because we've only got about a minute left, if I'll leave this to one person to take, so whoever wants to grab it first. If what needs to change for how we think about care and health systems? Does someone have one gem to leave us with? How do we think differently about these systems?
Can I say something? I know I just spoke. I'm thinking about what our group CEO, Dr. Gidenji, asked us once. Is it better to count the number of hospital beds in a locality as compared to the number of water taps? And I think that speaks to the way that we think about the health system. I think that we have been used to looking at the health system as what comes after disease. And the health system needs to be the entire ecosystem that maintains the health and well-being of our societies. So this one health perspective is what we need to change, so that then we're not looking at building more hospitals as compared to building the schools. We're also thinking about, could it be that they're coming to hospital because they didn't access water? So if you look at the person as a whole person, you'll be able to see what they need in the system and count the thing that matters to contribute to their health and well-being. That's what I would say. Thanks.
Okay. Well, I think we'll leave it at that because that's a relatively powerful thing. Vanya, you're shaking up the entire system here, but I think several of us would argue maybe that's exactly what's necessary to improve access to quality child and maternal care across the continent. Looking at the time, I am going to wrap up this webinar. So I want to say asante sana to our panelists and merci beaucoup. And thank you so much to all of you who have taken an hour and a half of your time to join us, to ask questions, to listen to our panelists. I've certainly found it to be very fruitful, and I hope you have as well. And Hani, I don't know if you or Professor Mbembe have any closing words.
Actually, Professor had words, but there is a storm right now in Johannesburg, so he don't have internet or any light actually anymore. But he's sorry and he thanks all of you.